These are some of the patients that I've seen in some of these private facilities. The first case, very young, 31, and I mean she had COVID, pneumonia. She had no medical history, and she had a sugar of 13, and she was pyrexial, and I sort of like, when I got to her, I said, but okay, why did they admit her? All right, then we couldn't really find much in terms of examination, but just some few crackles on the periphery. But this is what we then, when there's resources, you can do what we call a low-dose CT scan. Basically, low-dose CT scan, you don't need contrast. You just go there, you lie down, they take a scan, and then you then quantify the pneumonia. So how you do it, you work out on a score system, which is 1 up to 25. So you look at the pulmonary infiltrate. You can as well read also on the X-ray if you've got experience. You look at the size of the pulmonary infiltrate. So you will say, if there is just 5% involvement of the lobe. So remember, you're talking about the lobe. 5% involvement of the lobe, we will give 1 point. And then we say between 5% and 25, we give 2 points. And we say 25 to 50, 3 points. And 50 to 75, 4 points. More than 75, that means that whole lobe is almost wiped out. You got 5. So we know anatomically that we have 3 lobes in the right lung and with 2 lobes in the left lung. So the West score is 25. And the midpoint of 25 is 12.5. So we sort of have been using this scan to sort of categorize the patients in terms of the severity. However, I must say the timing is important, because if the patient presents early, you do a scan and you see nothing, and it does not necessarily mean that it's not severe. You have to find out from them as to when they started having symptoms. So this young lady, you can see she's got some COVID there at the bottom of the lung. And then you can see it as well on this other view there as well. Some there, so you can see it there. But this is hair blood test. I don't know if you can see, but if you can't, I'll read. The A1C here is more than 14%. All right? And the sugar, 26.5. So there's no doubt here that there's diabetes. But the question is, what kind of a diabetes is this? Okay, we'll come to that. So we say, we agree, all of us, she's got diabetes. Is the diabetes related to COVID-19? Does she have type 1 diabetes? Is it a latent autoimmune diabetes mellitus in adults? Is it a type 2 diabetes mellitus? And I mean, we know, I did not show you the whole scan, I just took some snippets. But from the scan, she scored 8 points. So when you say 8 out of 25, you will get 32%, meaning that 32% of her lungs were having COVID. And so, should you give her insulin? Should you give her oral hypoglycemic agents? This is an interactive session. So let's see. Let's hear comments from colleagues. What would you do? I think the weight, it might not have come out, but it was 65. Let's see. 65. It did come out 65. So, what do you say? Let's engage.
I would give it for one of the reasons. First one being they want to say it is about 40. That's the one that
Yes.
start with the insulin.
Okay. Any other divergent view? We take all views, different views. If you do orthopedics, they say one view is no view.
Yeah, my time. Yeah, I'll also treat her with insulin because she's got COVID. We're also going to give her steroids. So I think the best shot would be insulin.
All right. Any other view? There's another view there.
You can shout.
Excuse me?
Urine dipstick.
The urine dipstick, she didn't have ketones, but she had glucosuria. All right. So we're all in, this is a unanimous decision. It's not like Concord. There's no minority judgment. It's a unanimous decision. No doubt, this patient really needs insulin. There was that question, is this going to be lifelong? You know, is this short-lived? We'll come to that. Okay, the second case. Well, actually, this case was one of the most interesting case ever since the pandemic began that I've seen. And the good story is that this man went home, but after some serious intervention, 68-year-old gentleman, type 2 diabetes, he was on glucophage, slow release, a gram a day. That's all. And had severe type 1 respiratory failure, required ICU ventilation. And actually before that, his PO2 was 53 on high flow. And we then realized that we are not going to sustain this. We have to intubate him. And his random sugar was 15. And he got ventilated for 2 weeks, and then he was extubated. However, after extubation, there were problems. You know, his sugars were not really a big issue, but you will see, if you look at his, oh, this is not projecting well, and I wish I could, I don't know, is there any way we can do something about it? Because I can't even see it myself there. Okay, yeah, you can just tell, maybe you can just read for me. What I want to show you is the seriousness of the condition. One, the full blood count shows that the patient has lymphopenia, low lymphocyte count in keeping with the COVID. We didn't do the neutrophilic lymphocyte ratio there. But the D-dimer was very high as well, very high, sky high. And there is what you call an interleukin 6 levels, which were above 100, 114. We know that if you, yeah, that's a little bit better, thank you. There you see 116, and the CRP was 59. We know for a fact that if you do an interleukin 6 levels, you can sort of predict that this patient is going to respiratory failure. And we can also use the interleukin level and the CRP to also say that this patient is going to require high insulin levels as well. Okay, if you could maybe intervene again, please. Well, the kidney function was relatively preserved, but I wanted you to see something. Okay, I think that's fine. I can pass this one. Let's see. So this gentleman has severe disease as well, because as you will see, when we project this, is that there was some element of cardiac involvement. Look at the BNP. He started leaking BNP. We couldn't prove the myocardial infarction or anything, but look at his A1C. A1C was about, I think, 9.6. Yeah. Okay, we can go to the imaging. Look at the X-ray. This is really the only area that is giving oxygen to this patient is this part and this part. The rest is disease. They just called all over there. And then, well, as you can see the difference in the X-ray, this is after you can see the ET tube there. Patient was being intubated. Well, still severe disease. But then that is after 10 days of being ventilated and extubated. And then the nurse said, "Doctor, come here. I want to show you something." So please show me. I don't have the pictures of the abdomen. The whole abdomen was like, full of bruise. Patient was bruised, was receiving Clexane. I don't know now. This is an interactive session again. I think you guys can see the scan. This is a computed tomography of the abdomen. Patient, I'll give you the history. After the nurse showed me the bruise, I said, "What is the HB?" He said, "The HB, doc, is it's 6. Okay, where is the blood going? Where is the blood going? Okay, can we please stop Clexane? Yes, we can. But what do we see? Any taker? Do we have any volunteer here? Do we have any surgeons? No surgeons. The surgeons like these things. You're a surgeon?
On the left,
Yeah. Good, excellent. You see there? Huge hematoma. Huge abdominal rectus wall muscle hematoma. And as we actually go in deep into the pelvis, this is blood sitting there. You got blood sitting in the abdomen. And then we then get to, we say, okay, fine. We'll just go conservatively. We'll try and see what happens. The surgeons get involved. They say, "Look, do it." No, we're not touching these patients. We don't do COVID. You are supposed to sort out the patient. So we say, okay, fine. What do I do? Give him blood. But then you can still see it's actually even more clear. We were afraid that it might actually form an abscess. So it never did, and we never aspirated it. But then he went to the ward. As he was in the ward, I said, "Look, sir, you just made it. You came out of the vent. You need to change your mindset. You need to go home. I want you to go home." I said, "Doc, I can't walk." So why can't you walk now? Lift your legs. He couldn't lift his legs. And so we then decided that, he couldn't lift his leg. And then, well, these are just the findings on the CT scan before I come to that. And that's basically what he had, what you call retroperitoneal hemorrhage, which is a rare adverse effect in relation to to anticoagulation, a rare effect in relation to Clexane. Whether it was COVID related or not, I cannot tell you. But then we then proceeded that we realized that he wasn't really moving his limbs. We decided to test his nerves, and this was what we were told. And it looked like, as you know, that there is a lumbosacral plexus sitting behind the retroperitoneal region. And I think those hematomas were also impinging on the nerves, especially also the femoral nerve. So eventually, the gentleman went to a rehabilitation center, and that is the diagnosis. And I hope he's still alive. I haven't checked him. And then we go to the third case. Okay, the third case.
Can I comment on
Okay, you want to comment on the second case? Yes. Thank you.
Yeah. Thank you very much for the great work. I think with that said, with the condition of the patient, I would like to say thank you for saving that patient's life. But what I want to ask is, initially we're told we must not rush to intubate this patient. Is still the case because this one, if it was not he or she was not intubated, we know we have lost the patient. What is the latest now?
The latest status quo still remains. They say 60-40 chances, but I have a different view to that status. And well, it's just that I'm not discussing ventilation. If I was doing ventilation, I was going to give you the numbers that I've collected myself. But my view is that this is my approach. If you fail the high flow, sometimes I don't even think about the CPAP. I just intubate you. And we actually have sent quite a lot of people home. And we actually have extubated probably about 3 or 4 people this week that we actually intubated. So I think it's just the timing. And we actually did not know what mode to use then. In the first wave, well, everybody, when you said ventilator, most patients still refuse, but you got to persuade them that this is the right thing to do. They've got nothing to lose, because sometimes the CPAP, my view is that it should be reserved for those people like I've discussed that have high BMI, that we know what are the challenges. Firstly, they're going to have a challenge in intubating the patient. So my own opinion, if you come to me with COVID, I give you high flow, and then you struggle on high flow, I definitely intubate you. And we have seen good results as well in that. But you have to be on the lookout, because once you intubate them and then you give them high dose steroids, the inflammatory markers come down nicely, and at that point is not yet the time to celebrate, because you've given them high doses of the steroids. So what you should be on the lookout for is infection, because mostly they will develop severe gram-negative infections and demise, or severe fungal infections. So it's always good to look at the inflammatory markers. So my take, high flow, I love high flows. I don't know, is there anybody from the province here? My superiors, are they here? Okay. They mustn't see me, but I've just requested more high flows for my hospital of Ferreira, because the high flows, we know for sure that we have prevented ventilation. If I was doing ventilation, I was going to show you a patient where patient looked like was going to a vent. And I said, look, my friend, tomorrow if I come and you're still like this, shoot. Following day, okay. So high flow prevents, deterioration. You can, I think what people did because of the fear of ventilation. And we initially went to buy ventilators. It's a story of Mercedes, and Toyota. I love Mercedes, I love Toyota, but at the end of the day, you can't go and buy a Mercedes when you know that the Toyota can equally do the work, even actually better than the Mercedes. So what we should have invested money on should have been on the high flows. And but I know, well, you say yes, I know you all got high flows. Tavisho told me I know who got high flows, and I know some centers in the province are having high flows, but they're not using them. And high flow is actually the simplest way to look after this patient, because the beauty of high flow is that you can do it even in the ward. I spoke to the CEO of the Netcare group in Joburg 2 weeks ago, and he was telling me that they actually saw in the first wave, in the second wave, actually said, look, they are no longer going to buy so many ventilators. They will buy more high flows, prevent people from getting ventilators, and then get those that need ventilators to be ventilated. And we are saying that what we are saying is that there is a role for those patients that need ventilations, and where you struggle on the ventilation, then you can consider, if you're a good candidate, things like extracorporeal membrane oxygenation, which we have living proof of colleagues that we have done on ECMOs, and they survive. So that is my take, but the fear is still there. The fear is so huge. I have been trying this at my hospital in Roferera to convince my medical officers that, guys, please intubate this patient. Ah, no, doc, we'll intubate. Oh, POT is still good. Ah, okay, we'll intubate tomorrow. With COVID, once we say resus, it's over. Once you say resus, it's over. You're not gonna get that patient back. So you have to be able to say, this patient is hit. This is what I need to do. And you sort of plan, this is the one that I need to intubate, this one, two, three. And that's my answer. Sorry to be long. Sometimes I'm a pastor, But
Two more hands.
okay, there's still more hands. All right. Okay, that's fine.
I think you bring a very hot issue concerning food criteria of intubation.
Yeah.
We are in the other side of the thing in public sector, where unfortunately we don't have a.
I'm also there.
Then I wanted to ask you, those criteria of ventilation that you are talking about apply in the scenario where you actually have those ventilators available? Because in our case, we don't have any, and it's so frustrating when you start to call everybody around and they don't even let you ask the second question. The first question is they say, you're looking for COVID ward ICU, they are full. Okay? So those criteria of ventilation, do you apply in a public sector? That's my first question. And my second question is, what is the mortality of the patient in ventilator according to your experience? Because I hear mortality of 80%. And I have the feeling in your case that is not your experience. The mortality is far better. So 80% of patients in ventilator, only 20% came out.
Okay, thank you. I think you've raised a number of issues which are quite pertinent to this discussion. I agree with you. We are severely hit. I think what people don't know is that we are severely hit, and that information is not out there to the community, because literally speaking, if you need a ventilator, somebody has to demise first before you get it. So I must actually warn you, you and I were in trouble, but at least because of being healthcare professionals, we tend to be prioritized. But even if they prioritize you, there might not be a machine anywhere, whether it's private or government. We don't have. This is just, the numbers are huge. Yes, people don't even want to engage you. They say, oh no, you know what, we don't have beds. and it's a challenge. But should you have any problems, which hospital is that? ML Hospital. Okay, you send to Witbank, but if you have challenges, you're welcome to speak to me directly. We have taken some patients from MLO and assisted those patients. We do have ventilators, but we don't have a lot of them. I must say, we do have ventilators. We don't have a lot of them. In terms of the numbers, I tend to disagree with that number. The number that I probably close, to it was, for me, I say at this level of the third wave, probably I would say it's almost at the level of 50-50, 50%, 50% survivor. But that depends. There's an important right on that statement. If, for example, there are patients that we know that had we actually intubated them earlier, they could have done well. But you would wait for like 24, 48 hours with no ventilator, and then you try and put the patient on the bureau system in Gauteng and wherever, no ventilator. So that is a challenge. And I don't think that message has been communicated properly to the community. And we have reached a level, I hope, that maybe we're going to come down, but the numbers are huge. We're sitting with over almost 30, 40 patients in ROC, with COVID. Every day we're taking patients. And I must say, my colleagues there in the other disciplines, they don't like me anymore because I've taken their wards. We've opened new wards that we didn't have. We have taken an orthopedic ward, which we had to plead with them to give us the ward. Now we have taken an oncology ward as well. We're going to use it for COVID. So, and we have got our own wards as well with COVID. So it's COVID everywhere. So if you think you are in a very worse situation, I don't think so. But I think if you need help, give us a shot. We'll assist where we can. I hope it answers all your questions.
Thank you very much for the presentation. I would like to find out, you insisted on the use of high-dose steroids and checking the blood markers.
Yeah.
Can you please touch a bit about which one can you monitor and which one is related to COVID most? And another question is about the ventilator.
Yes.
You said that there is a ventilator.
Excuse me?
At your hospital,
Yeah.
I would like to find out, do you have any criteria that you can share with us so we know that if I have a such patient, I can call and the patient can be transferred? Because since the COVID from started last year,
Yes.
in my hospital, which is our hospital, we never succeeded to send the patient to Rockville.
Yes.
Every patient, you see, this is, in terms of the risk factors, the patient is not at risk of dying, but we fell with high flow oxygen, but we are failing to send the patient out of ventilation. So can you just share with us if you have any, so when you go down there, we do that.
Yeah.
Such patient I'll send to you.
Okay, thank you. You refer to us for temper, isn't it? You refer to us for kidney and or you refer the other stuff to temper, but that shouldn't be an issue. I think one of the easiest way, as Dr. Masina said, is very difficult to find me on the phone, like to talk, but I'm very good with the WhatsApp and text. That if you send me, you've got a patient like this and that, we always make a plan. I remember there was a patient in the second wave in Matigwan, where the patient was clear COVID, but they were waiting for the results, and then there was a standoff between my medical officers and the hospital there, saying, "What do we do with this patient?" So they phoned me directly, said, "Bring the patient." We took the patient, and then when I get there as well in my hospital, the nurses were fighting me, said, "But no, Matu, you can't take the patient. You haven't got COVID results yet." I said, "Well, I can see it's COVID, so I'm taking the patient." But fortunately, I got vindicated after 24 hours. The results were positive, So, but it was a big storm, in terms of beds, So people are really. We don't have. If you ask me, do we have enough beds? No. Do we have enough ventilators? No. Do we have enough doctors? No. Do we have enough nurses? No. We will never have enough. but we will have to work with what we have. The challenge is who do you take, and it's a very painful process, because if you are 60 and you've got comorbidities, your chances really are very, very low. But you're above 60, you've got no comorbidities, we'll give you a chance. I mean, it depends what you are doing. I say, if you're a 60-year-old, or, what were you doing before? I often give an example. When you're running the Comrades Marathon, but nowadays, okay, you can't run it because there's a virtual Comrades Marathon. Perhaps maybe you were running the virtual one. But we want to know the pre-morbid functioning of the patient. So there's no point in saying that you want to put somebody on a ventilator that has not walked for the last 2-3 months. It's not going to help that patient. But somebody you know he was walking, is functional, you give a chance. But the criteria to intubate is simply, we're using this very same criteria. Anybody with a PO2 of less than 60, that person has respiratory failure. By definition, must be on a ventilator, period. That's it. So that has to be obviously taken into context. We're not talking about somebody who had chronic, TB with fibrocavitary lung disease. Those patients with that PO2, low PO2, they are used to it. We're talking about somebody who's being okay, they get COVID, and then they decompensate. We got to do something. PO2 less than 60, bring that patient. If we have a bed, we'll take the patient, all right? If you don't have a bed, please don't get upset. We just say to you nicely, we don't have a bed, but we'll put on the list. So I think the message that I'm trying to get across, if they tell you that there's no bed, they're supposed to tell you that, give the details. They must phone you and say, well, we've got a bed for that patient, you understand? So it can't be on a restaurant mode, first come, first serve, and all those kind of things, But if there's a patient there that needs to be transferred, they must put in, we've got a book, we put them in the book, we give you details, we phone you, where's the patient? But sometimes also it's difficult with the system, because you've got permanent doctors working there in the hospitals, and then you've got sessional doctors. But often at times, the classic example is that, look, this patient is not well, I just got into the shift, I don't know anything about the patient. So that obviously does not inspire confidence to the other person who wants to listen to what you're saying, because it comes out as if like, well, I really just want this patient to get out of my face, I really don't care. And that shouldn't be. We should be saying that once the patient has been handed over to you, you have to give a comprehensive, full information so that we can be able to accept the patients. Any other questions? Are we clear? About? Oh, yes. No, well, we don't really want to get very fancy. The CRP is okay. If you do a CRP, we are happy with the CRP. CRP is it's okay. We're fine with the CRP. In a setting where you feel that the patient is probably getting more sicker, but the CRP is down and you're not so sure, then you can do a procalcitonin to see if there is no superimposed bacterial infection or so.
Sorry, thanks. I saw something the other day of a doctor in Gauteng that I know it's a high-risk procedure, but he did a bronchoscopy on a patient with safety line, where he said it was thick mucus plugs that's formed with the COVID. And then another thing is the lung fibrosis. What can we do and how can we prevent it early on? And the other thing is, are we doing enough, maybe even with our mild disease? Can we not prevent some of these complications if we start educating people on lung exercises? Simple things like blowing water in a bottle.
For sure, we can. We can definitely, encourage people, especially with mild disease. And what was your other question? Was on the? Oh well, yeah. Actually, I thought I had put the case scenario here. I wanted to show you a classic example of a patient like that. But I think one of my MOs is here. I showed him a picture before. This gentleman had, serious mucus plug. The tube completely blocked. You go there, they say, well, how do you detect it? Patient is fine, is ventilating okay, FiO2 less than 60%. You come in the morning, the nurse says, no, I started desaturating, then fagamafuta, increase the FiO2, 100%. No, but it doesn't make sense. Complete blockage of the ET tube, patient taken in for therapeutic bronchoscopy. They cleared the mucus, reintubated the patient again. 7 days down the line, ET tube blocked, extubated, reintubated. But the good story is that the man went home as well. After having 2 attempts of, blocked ET tube. So mucus plug, yes, it is a reality, and there are those kind of patients that would benefit for that kind of procedure. I don't think all the patients develop mucus plug, but there is specific patients. The ICU or high care sisters will always tell you, no, doctor, the secretions here, secretions here. When they tell you that, you must know that is the candidate of that. But the challenge is that, do you have enough resources to do that? We don't have. And if you're presenting within 10 days like that, who do you put the staff, because it's a high risk procedure. Do you put the staff to get exposed to this thing, or what do you do? So it's a bit of a challenge, but for carefully chosen patients, I say I fully agree with you. I think the doctor you're talking about is Dr. Emmanuel Taban. Yeah, I fully agree. I fully agree to that concept, but I'm saying that you cannot do it for all the patients. There are those specific patients. But I thought I was talking about sugar, but now I'm talking about okay, was there any other question? Okay, let's do the third case. Well, this is she's 57, asthmatic, but she's still alive. The severe COVID, she's in ICU, she's on a ventilator. She had high dose steroids, like 8 milligrams decadronate hourly. She got lucky with this remdesivir business, and she was on this Maxipin. She developed sinus tachycardia and high glucose, no previous diabetes. And then, my colleague, where's my colleague now? Oh, no. IT guy. My IT guy really should sort me out. But when I'll show you the A1C on this patient. And then I would show you the sugar chart as per ICU. Yeah, if you can also enlarge that, please. And so you would make up your mind as to what the story is. Okay.
Few more.
There is clear now, okay? Oh, what did I do? Okay, you can see there A1C, 7.6%. We know they often at times give you this statement, but is this patient diabetic?
Yeah.
Yes. What kind of diabetes?
Type 2.
Type 2. Okay. Do we know? Do we have proof for that? We don't have proof. Okay. I don't know if you can see the chart, but it doesn't project out well. You can see this is the sugar reading, all right? And then this is the insulin requirements. Can you see that?
Yes.
And then, well, this is a CAT scan. We're just showing the COVID there. All right, and then, well, still again on the CAT scan. So how would you manage this patient? Well, I've given you an answer. Novorapids, protrafane, insulin infusion, metformin, diglycosides. So you need to give insulin to this patient. All right? You can decide about oral treatment when the patient is going home. But in this instance, I fully agree. Yes, certainly looks like a type 2. We could easily get away with oral treatment here. Is there any question on this patient? Well, we go to the next case.
No questions?
No questions. Okay, let's get to the next case. This patient actually still in hospital as well. Look at that. She's 48-year-old and she's got hypothyroidism. Perhaps maybe we should blame the thyroid, for this BMI. We mustn't just say, oh, well, 1, 2, 3. Just blame the thyroid, and then the severe COVID. And there was no history of diabetes. In actual fact, I've adopted sort of an unwritten policy that if we are indirectly discriminating. We said, okay, if you've got a BMI, we'll check your A1C, all right? So that's what we did. We need to see, all right? This is important. They have to see it because you will see the A1C on admission, and there was those questions about whether is this diabetes related COVID, is it temporary, is it a long-lasting issue? Nobody can give an answer, but as we look at the A1C, so I think you need to focus on the A1C on admission, and you will see what the A1C says. And the A1C, it's in a space of less than 2 weeks, I think, but the A1C is completely different on the same patient.
Few seconds.
Okay, are we coming good, my IT guy? We're coming good.
Yeah, I'm trying to solve this
All the
one.
problems.
No, it's fine, yeah.
Okay.
Okay.
All right. Well, where's the A1C? A1C. Okay, there's HbA1C. All right, you follow it. I give you a date. This is a recent patient. 12 July. A1C 5.9. And then this is what? How many days from the 12th to the 27th? 15 days. Look at the A1C. What is it? Somebody can just... 6.6. 6.6. What did we say when it's 6.6? Did we say anything?
Anything greater than 6.5.
Anything greater than 6.5, and we say you are diabetic, right? So now, this is a sugar chart, but I don't know if you can see. You can see the sugar up there. You can see the amount of insulin there. So you can see a scan. Actually, this lady was very, hit quite severely. I think it's not. She scored what? Look at that. It's not really projecting well on this view, but you can see the COVID. But on the axial cut, when we work it out, 21 out of 25, which is obviously it's more than a distinction of COVID. You see. So what happened? So what do you say? So what is the diagnosis?
Maybe let's comment first.
Okay.
Yeah, thank you. Because according to our understanding, HbA1c is a 3-month period, 120 days. So I'm not so sure why was it repeated. Is it because it's of a study, or you're trying to study to see why it happens. I'm just trying to figure out.
I'll
Because,
tell you.
yeah, because it gives us an impression now to say, is this HbA1c reliable?
Very reliable.
Is it reliable?
Yes.
Then, because initially it was 5.9.
Yeah.
Now it's 6.6.
Yes.
Are we going to say it's COVID-related diabetes?
Well, the answer, they say the answer lies with the masses.
Yeah, because I think on those bases my impression was if I've done HbA1c now, I need to repeat it in 3 months.
Okay, thank you for an important point.
What's your diagnosis?
Does he have a diagnosis?
Okay, it's COVID-related diabetes. According to
There's one more hand.
Okay, there's one more hand there. Yes. Yeah. Okay, thank you. Any other comments? Well, let's just clarify the A1C. So, there's a question there. Okay.
Yeah, I was going to say that there's a lot more likely it's a combination of these factors because it could be underlying diabetes worsened by your steroids, worsened by your COVID. Is it important that we put it in one of these categories?
Well, we could improve it from admission. So we have an A1C on admission. Okay. So let's just clarify the A1C matter. The A1C, remember, yes, you're supposed to do it every 3 months, but what you need to know, the A1C gives you more of the information precisely in the last 2 to 4 weeks. So even if it's giving you the average of that 3 months, but it's more, inclined towards the last 2 to 4 weeks. So that information has to come across as well. But what is the answer? We need to know the answer. Is this obesity-related diabetes? Is it just a new onset diabetes mellitus? Is it COVID-19 related diabetes? Is it a steroid-induced diabetes? Does it matter as to which diabetes it is? Should the focus not be on the reasonable glycemic control?
No, that's very correct as well. Because what matters now is how you're going to treat the patient.
For sure. So how would you manage these patients? So we'll manage that patient with insulin, and then we will think about oral agents on discharge. All right.
Questions. My question is, with COVID-related diabetes, once the COVID is out, do we treat them for life?
Well, we still need more literature there, and this is part of the literature that we are trying to gather.
Because maybe that's why the distinction is important.
Yes. Any other concerns? We told you we'll try and make it exciting. So I see you're all excited now.
This is not boring. It's a very good discussion.
Okay, we can get to the next case. Case 5. Okay. 69-year-old lady, type 2 diabetes mellitus, systemic hypertension, obesity. She's got a BMI of what, 32. She's on massive doses of insulin, which is Novomix or Actrafane, 54 units twice a day. And now she presented with severe COVID pneumonia. Though she's sitting in the ward, a CT score was 15, which is roughly about 60% of the lungs hit by COVID. And she seems to have progressed well on the nasal cannula. And she's getting the Cadron and the Remdesivir, which she said she'll pay for it, which cost about 4,000 to 5,000 for 5 doses. And then the sugars were very erratic. Can you please sort out the slide for the sugar so they can see it? Well, this is sugar monitoring by our colleagues. Some of them are here. You can see you've got the reading there, 10 and 20 being high, 11.9, 5.6, 9.6, 12.3. I don't know what number is this. What do you see there? I can't see. 12 and then 16 and this. And look at that. Yeah, almost going towards ketoacidotic range. So, but she's reasonably doing all right. Well, this is a CAT scan, just showing COVID there. You can see the typical distribution in the periphery of COVID. And then, well, this is just the axial cut. You still see the COVID in the periphery. And I want to show you her results. Can we increase the size there, please? So I want to show you the blood results in terms of saying is she severe or not, and in relation to the sugar control. You can certainly see CRP very, very high there. All right, and then what else do we see? Iron 6, you see there? Yeah, so it's very high. So already from admission, you can say like, you shouldn't be surprised by day 5 or 6, then when she starts decompensating and going to ICU, because you would have seen it from the beginning that this patient has severe COVID. And when we look at A1C, look at that. Well, I mean, for her age, this is reasonably, good glycemic control. It did spare her from the severe COVID. It didn't. So even where you have, reasonably controlled sugar, you still suffer disease, severe disease. So how would you manage this patient's sugar? Would you stop maintenance insulin, since that she's taking a huge amount of insulin? Would you rather instead use the oral hypoglycemic agent? Would you use the sliding scale alone because you're worried that she's been taking a lot of insulin? Or will you keep the maintenance dose unchanged, supplement her requirement with a sliding scale? I don't know the answer. What's the answer? The answer lies with the masses. Number 4. For sure, I will definitely do this.
Number 4. Everyone says number 4.
Okay, and there's another hand there.
I think 4.
4. Oh, you agree? Okay. All right. Can I pass this case? Are we happy with that case? It's a clear-cut patient that's known with diabetes. And yeah, this case here, it's a very interesting case. We were talking about mild, moderate, severe disease as to, should we rather say if you're obese, you have severe disease, or by default. This is an example of such case. 52-year-old lady, look at the BMI there, 44. Well, sort of admitted for me by my colleagues in ER. She really had a very, you look at her, you say, but why is this patient here? I've got a lot of sick people on ventilators, and why is she here? She's like sore throat, fever, and headaches. She said, but this is mild disease. And the casualty, was more humane. They say, look, I feel compassion for you. You stay far. I'll admit you. Then my door will come in the morning. Will discharge you. And then, I don't know, something at the back of my mind just kept on saying, but no, you can't discharge this patient. This patient is obese. You know what's going to come. And so she was all right. I just kept her in the ward. And the case managers were actually on my case, but doctor, you're giving patients oral steroids. Can't she take it at home? We're doing nothing for the patient. I said, okay, maybe I'm doing something wrong. All right, look at her x-ray. Really clear. No COVID there. On admission. X-ray clear. Well, wait until you see. CAT scan. They even say the conclusion, there is no evidence of COVID in the lung, no evidence whatsoever. So he said, but why are you keeping this patient in the hospital? All right, maybe you want some Mercedes, since you said you like Mercedes, that's why you kept her. But it wasn't about Mercedes. It was about more of having a futuristic approach and be able to focus patients. So look at her. 8 days, still in the hospital. What happened? Look at that. So what happened? Let's engage. What happened?
She get Delta in the hospital.
Okay, well, there's a concept of nosocomial COVID, but we know she came in with COVID. She developed nosocomial pneumonia. She picked up maybe, is it the Delta variant in the hospital from one of the doctors, maybe, or nurses, or cleaners. What's happening here? Let's show you the results. Can we adjust the results? What case number is this? Is it case 6?
Yes,
Okay, I think this is just one last case we are done. Okay. Well, my responsibility is to provoke your thoughts. Look at the CRP there. And this is on admission. So she's admitted with that, and then our casualty officer there decided to do an IR6. All right, you see it?
yes. Yes.
And look at the CRP. And then she kept on asking me, doctor, what's the infection rate? I said, ma'am, it's still high. I'm going to try and see if I change your antibiotics. And then again, was still high. But look at that. She's obviously has developed what? She has progressed. So what do we learn from this case? We must never ever underestimate the impact of obesity on COVID. We should be less excited, when you have patients with COVID and obesity. You mustn't just say, you okay, go home. If they go home, yes, you must just keep on asking them to come back for follow-up if they have short breath. And you must just trust your instincts. Obesity on its own as well is a pandemic. And we know that type 2 diabetes as well is a pandemic. And listen to the patients and give them the benefit of the doubt. This is famous with the doctors, and the nurses as well. Oh, her patients, Dr. she's just like complaining. She's just a crybaby. She needs attention. And the doctor comes with a big word. She's got some supratentorial stuff ongoing. So, and then, so we have to treat these patients with obesity, with caution. I'd like to engage on this case and then do the last slide, I think. And yeah, I think we can do the last. Any questions on this patient? Have we learned something on this obesity story? Okay. And COVID. So we mustn't get excited, guys. It's good to be excited, but with some degree of measurement or so. All right, any questions? You all right? Can I proceed? Is that they normally call it the graveyard session, just before lunch?
Yes.
Which case is this that I'm doing? All right, can we do this one?
Sure.
Yeah, no.
Okay.
Basically, I'll talk. Basically, there's a lady who actually had, as I said, the three pandemics: diabetes, actually obesity, and COVID, and came in with ketoacidosis. And unfortunately, I don't have A1C for you for this patient. So the highlight of this case was just to show you that you do have patients presenting with diabetic emergencies, and the challenge is to say, how do you treat those patients? And the treatment is still the same way you were taught how to treat ketoacidosis. You do it the same way, but you have to exercise caution in terms of the steroids dose to try and make it maybe twice a day for a better control. And this is after DKA. She was still requiring insulin, and this is her results. Sorry, I don't have an A1C, but as you can see, going from this way to that way, you can see the CRP very high there, and then with the steroids sort of nicely coming down. Had problems there of sodium as well, but patient is doing all right. But I can show you the X-ray of the patient. Patient couldn't even get to scan because of unable to breathe. You can see this huge opacity on the periphery. You can see it as well at the bottom of the lungs. You can see it as well here in the middle lobe. You can see quite huge. So this patient had severe disease, and really, what do we learn out of this case scenario? Well, really doesn't really matter, whether you are type 1 or type 2. You will get hit. Just know how to treat ketoacidosis. Most hospitals have protocols. You just use the protocols. Would you give that patient steroids? What are the other options that you can do? But certainly you need steroids, because steroids have really become a cornerstone of managing this condition. And I would like to conclude by acting like a neurologist. The neurologist, if you don't know anything, just give steroids, the patient will get better. So that would obviously, I think, I would want to emphasize this and say, I thank you very much for listening to my story. And we know that this story is our modern day reality and it's not a myth. You know, you remember when it started, we had a lot of even colleagues saying, oh, it's just a flu. But I don't know where those colleagues are. I hope they're still alive. And I remember, even if you are vaccinated, please take all necessary precautions. Do not relax. We need you, all of you, on the ground, and the community needs us more than any other time. And I shall conclude this forum. Unless if there's any questions, we can engage the questions, but I don't want to say, Dr. Massimo, I don't want him next time if he has something, and then he doesn't invite me, say that one talks forever. So I am trying to stay within the confines of the time and what I've been allocated. There's a question there.
Thank you so much. Wonderful. You here, as always, sending decisions is always nice. So I want to just be opposing to the issue of steroids, as you mentioned here, neurology, and also giving an example of a case of this case. I think you mentioned that you've given also steroids in that case, and looking into what I would have thought, maybe the patient doesn't have an indication for steroid at that moment. Maybe itself could be another issue. Previously, there were some studies looking into natural immunity on COVID patients. So they picked up that most of the patients who had severe diseases, in fact, they lacked natural immunity. And in my thinking, I looked into the issue of steroids that were given to those patients with severe diseases because they are on oxygen. So part of me thought, are we not tampering with the immune system to learn the pathogen? Yes, of course, in that moment, you'll be weighing the benefits over the risk, but giving these patients steroids while they, don't need them, they are good in invalid comas, don't need them. Are we not in the long run disturbing that immunity to be the pathogen?
Thank you. The steroids really is a very contentious issue. I personally don't like steroids. You know, I look after a lot of autoimmune disease, which is my passion. Diseases like rheumatoid, lupus, systemic sclerosis, all these inflammatory bowel disease, which those are the conditions that make me, happy when I look after them, and I try not to give them steroids when there's no need. You're quite right that if you obviously lack immunity, you would obviously going to dampen that immune system. And the answer to your question, definitely the steroids do impair the immune system. And what we have seen was that if we close our eyes when we look at these patients, they developed severe, overwhelming gram-negative sepsis with what I call the so-called superbugs, whether you got an A. baumannii or a resistant Pseudomonas. So certainly, yes, it does. If you look at that recovery trial, obviously, we had suggested that you should be at least on oxygen to get steroids. But you and I know that we are learned people, and it's always nice when it's somebody else. But if it's you, because you got that inside information, or if it's a relative, would you say, oh, but I'm not going to give you steroid because you're not on oxygen? And I think it's an issue of just a location. Those that need steroids really, or they have a potential of getting severe disease, I would advocate for them to get steroids. But yes, remember, the steroids now we're just giving it, acutely, but still high doses. And as I indicated, the complications of steroid use, it doesn't end there. Those are just acute complications, and there are long-term complications of using steroids as well. So is there any other questions? I hope I've answered you. There's another question this side.
Thank you very much, Dr. Masua, for the insightful and comprehensive presentation.
I think this voice I recognize. I recognize it from my mobile phone, but
that's good and uses all the senses. My question, I attempted to ask it earlier, but then I thought maybe it's address that question. But when I look your case scenarios, I just want to check in terms of the severity of COVID diabetes in relation to the age group, the younger, and you are less who have a severity than the other. Because I was looking your scenarios and find that only one case that was almost below 8 years, and most of your cases were above 8 years.
okay. Okay, thank you. I think it's a good observation. What we have seen is that that notion of saying the COVID is for elderly people, it's really entirely not true. We have actually seen, I just couldn't really have enough time to gather some of the files at ROP. We had seen, I think we'd seen very young people now between 20 and 30 now that are still in the unit with severe disease. And some of them really no comorbidities. So we actually sent one gentleman home yesterday, I think at ROP, who was a bit, obese, but he was 29, and diabetes, had severe COVID as well. So does the vaccine work? Yes, definitely does, because what we have seen at ROB is that we're starting to see more young people now. And we are not seeing the senior citizens because they got the vaccines. So certainly that notion of saying is for old people, we must just forget about it. We've seen severe disease in young people. Any other questions or comments?
Doctor, thank you so much for this beautiful presentation, inspiring the guidance of us. Sorry, I'm coming back for the criteria of intubation from another hospital, as you know. In a setting where you have very limited resources, and we are talking basically not like a high flow, like a polymass. I am encouraging my team to do a little triage every time we have a patient. That triage includes the age, comorbidity, frailty score, and the SOFA score as possible as it is in practical. So we make something that we call intubation committee, where we put all the patients, how many patients we have here, who may classify for intubation and ventilation. We usually try for beds when it's between red code, orange, or yellow code. And the most of the time, the thing seems to be more palliative on a green code, talking about elderly people, multiple comorbidity. Is it the right approach according to your opinion?
Well, I actually differ with that view, but I think once you outsource the responsibility of the treating doctor somewhere else, it becomes difficult. I'll give you a classic example. They are doing it in all these private hospitals using the SOFA score, and I had a gentleman. He's over, I think he was 58, he's still alive, had a retroviral disease. And so then they said to me, well, we've done a SOFA score and we have tried him, as you would have said, red, orange, and yellow. And we think your patient does not qualify. and then they made him what you call yellow. So meaning that if you're yellow, for those that not familiar with the score, if you're red, you need, you definitely for full ventilation and all the treatment, you go all the way. If there's a ventilator, you get it immediately. If you're orange, you will get it if it's available. If you're yellow, that's the only time where I saw the importance of a yellow and a red card. In this instance, they say the yellow card, they give you a yellow card, it takes you out. But they give you a red card, you are in. So that we ran into trouble. And I then had this guy, CD4 count 198. Okay. And then they said, but yeah, the viral load is 59. But he did tell me, he said, doc, but I missed some doses for a week. So what I said, like, guys, 59, okay. What is a suppressed viral load? No, we're not sure, doc. But I said, but it says less than 50, so you're just gonna throw him out with 59. I said, no. I said, no, I fought. I fought for the patient. And I said, you're going to see that patient and make that patient red. You're gonna give me a ventilator. I'm gonna ventilate this patient. And I ventilated him. Guess what? I extubated him 2 days ago. And so, you understand what I'm saying? Because I think that decision has to be, yes, it's good to have that track system. It sort of takes pressure out of you as well as a treating doctor. You can sort of outsource that responsibility somewhere and say, look, you're yellow, what can I do? So you understand what I'm saying? But that's why I love guidelines and protocols, but that should not replace your independent thinking. It shouldn't just be, written on a hard rock and it's like this, you can't do it, it's like this. And we should be able to exercise some independence in that regard.
Or we and only we will document whenever we fail to get a bit.
Well, it's a very difficult situation to deal with those families. So this is what happens. You would phone them. Sorry, sir, I'm Dr. Madu. I'm a physician looking after your father. I've got no ventilator, and your father has been triaged or yellow or orange, and there's no ventilator. So I really don't know what to do because I try and put him on the bureau system for halting, but maybe we'll get a bed. And then everybody gets, they start phoning colleagues. Yeah, they say there's no bed there. Can't we go and buy a ventilator? Yeah. Oh, it's really highly charged environment, but yes, the triage team, I agree, you do need them, but you should be able to engage them where you feel that you are grieved. Then you engage them and say, look, no, I don't think that's the case, and which I do that all the time. In an event where I feel that I'm not happy about certain decisions, I express myself for the benefit of the patient. So I think you're doing a good job there. Maybe you should give me more people as well. I have my own team and help them to triage in my hospital. But yeah, thank you very much. Any other concerns? Okay, thank you. Yeah, time, we are up, they said up to 1:30, and they're going to kick me out here now.
Never.
All right, thank you very much, guys.